further ado, I would like to invite Dr. Hartigan to start the program today. She's going to talk about the rehabilitation aspect of managing failed back surgery syndrome. Dr. Hartigan?
Good morning. Thank you so much, Jerome and Allison, for inviting me. It's great to be here, and thanks to the North American Spine Society for a great conference. I have a single disclosure. I receive royalties from an entry that I authored in Up to Date in Medicine. My librarian and I performed a search on rehabilitation, physical therapy, exercise, failed back surgery, lumbar spine surgery, in numerous iterations to find articles related to this topic. We ended up locating 3 relevant articles, which I will review. In the first study, Jens Brox and his colleagues from Norway published a prospective randomized controlled study in pain, looking at 60 patients with pain lasting longer than 1 year following lumbar disc herniation surgery. They randomized the subjects into 2 groups, either lumbar fusion surgery with transpedicular screw fixation versus a group that underwent 3 daily sessions of cognitively oriented exercise for 3 weeks, averaging 5 hours of exercise a day. In the program, a message was delivered to the patients that they would not do any harm to their disc or back if they engaged in ordinary daily activities. The exercise patients were encouraged to move and bend normally and to avoid caution and fragility. They were challenged to perform activities that were previously labeled as not recommended, such as vacuum cleaning, jumping, lifting, and ball games. The exercise consisted of endurance, coordination, flexibility, strength, and core work. The primary outcome at 1-year follow-up was ODI, and improvement was deemed in advance to be significant if the change in disability score was greater than 12%. In the surgical group, ODI scores improved by 19% at 1-year follow-up. In the cognitive intervention exercise group, the ODI improved by 29%. The ODI improvement was statistically significant for both groups, and there was no statistically significant difference between the ODI outcome in lumbar fusion and cognitive intervention plus exercise group after failed lumbar disc surgery at 1-year follow-up. Both groups demonstrated what the authors had previously deemed would be successful at 1 year in response to the Global Disability Back Questionnaire, meaning that they responded that they were doing excellent, good, or fair as opposed to poor or worse. And 50% of the fusion group reported this, with 67% of the cognitive intervention physical therapy group reporting this. The secondary outcome analysis revealed that only the cognitive intervention plus exercise group improved significantly at 1-year follow-up for the other outcomes presented here. The posterior fusion surgical group did not improve for any of these outcomes. The next study from Turkey randomized 100 patients who the authors had labeled as failed back surgery syndrome patients who had persistent low back pain for an average of 2.5 years following lumbar surgery. They randomized the subjects into 4 arms: isokinetic or equipment-based exercise, dynamic lumbar stabilization or equipment-free exercise, a home exercise group, or a control group. The type of surgery was not recorded. The isokinetic group and the dynamic lumbar stabilization groups met 3 days a week for 8 weeks for about 30 minutes per session. The home exercise group met once to get an exercise program that was recommended to be performed in a graded fashion 3 days a week for 8 weeks, beginning at 5 repetitions for the 15 fairly challenging exercises and working up to 15 repetitions over the first few weeks and then maintaining that. There were phone calls made to this group to encourage compliance. The control group met for 2 sessions for 2 weeks to receive some education about activities. In both the isokinetic and the dynamic lumbar stabilization group, the pain, disability, psychosocial measures, as well as the progressive isoinertial lifting ability improved significantly at 3 and 6 month follow-up compared to the home exercise and control group where no significant improvements were seen. There is only one other relevant study looking at rehabilitation for pain following lumbar surgery. This is a prospective study comparing outcomes following aggressive rehabilitation in 122 chronic low back pain patients with and without previous surgery with 3-month and 1-year follow-up. The average duration of pain was similar between the surgical and non-surgical groups at 4.1 years. 31% of the group had undergone previous lumbar surgery, with 15 undergoing 1 to 3 level fusions and 23 undergoing simple decompression. The treatment included advice to the subjects from the physicians and physical therapists about the potential of improving back function and an explanation that pain with activities did not indicate harm. Treatment consisted of exercises for flexibility and strength to the trunk and lower extremities and for endurance and lifting. Subjects were encouraged to perform exercises at their highest possible level with the expectation that resistances would be continually increased during treatment. The occurrence of pain during treatment was expected, and patients were encouraged to work through tolerable pain symptoms. The patients underwent 3 times a week sessions, which at the time took place in a group setting of up to 8 patients per setting. The sessions lasted 2 hours at that time. Behavioral techniques were used to promote wellness behaviors and extinguish illness behaviors. The treatment time averaged 8 weeks, and at discharge, the subjects received specific individualized recommendations concerning recommended post-treatment exercise routines to be performed at home or optimally at a gym. We reported 3 and 12-month post-treatment follow-up results demonstrating significant improvements in flexion, extension, and straight leg raise flexibility. We also reported significant improvements in 4-repetition back strength, 4-repetition lifting ability from floor to waist, and disability for both the surgical and the non-surgical groups at 3 and 12-month follow-up. As for pain, only the non-surgical group had significant reduction in back and leg pain at 3 and 12-month follow-up, while the post-surgical group did not. We did note that the post-surgical group had significantly greater active workers' compensation involvement. All 3 of these studies looking at treatment for continued pain after lumbar spine surgery used graded exercise as the primary intervention, and 2 of the studies used cognitive intervention. I looked at the outcomes from our Spine Center REDCap database from 2012 through 2016. I found that we had data on 134 post-lumbar surgery patients who completed our current program of intensive, quota-based, progressive-resisted, non-pain contingent, cognitively oriented intervention, affectionately known by our patients as boot camp. I'm presenting this data because it is a larger cohort than any of the other available studies that I presented. In our group, 89% had 1 or 2 surgeries, and 11% had 3 to 5 surgeries. You can see the demographics. We have now streamlined our program to 2 times a week at 45 minutes to 1 hour max per session for about 6 weeks maximum, so our patients average about 11 physical therapy visits. At the completion of treatment, we documented improvement from initial to post-treatment back pain, from 5.1 at initial evaluation to 2.8 for a 45% improvement, and we documented a 38% improvement in leg pain. There was significant improvement in ODI with a 44% improvement. There were improvements in average flexion, extension, and straight leg raise at 23%, 69%, and 23%, and the degrees of initial and discharge are available in the graphs. As for strength, the 4-repetition maximum resistance for floor to waist lifting increased by 69% by 115% to 33 pounds at discharge for this activity. So this more focused treatment for failed post-lumbar surgery patients resulted in improvement in all of the variables at post-treatment. Unfortunately, we do not have post-treatment follow-up data for this group of 134 patients. Let's turn to the state of individuals with unsuccessful lumbar spine surgery. First, let's look at activity levels. National guidelines recommend that we perform greater than 150 minutes of moderate to intense activity per week. Only 52% of the general population meets this threshold, which is discouraging. A prospective study from the Hospital for Special Surgery last year reported physical activity for 422 patients with an average of 2 years post-lumbar spine surgery. Only 26% of this group met the threshold for physical activity. This is even more discouraging as this study was looking at all post-lumbar spine surgery patients, not failed surgery patients. These were patients who were supposed to be successful. However, among the variables associated with not meeting physical activity goals were status of revision surgery at study entry, which included 21% of the cohort, and those having subsequent surgery after the index operation during the 2-year interval, which included another 15% of the cohort. The physical and psychological state of the population with unsuccessful lumbar spine surgery is poor. The post-surgical patients in the cohorts that I presented are distressed. There is significant literature documenting central sensitization in the setting of chronic benign pain. Chronic pain is associated with complex changes in the peripheral and central nervous systems. There is amplification of the processing of pain from the originally injured body part or tissue. This results in perpetuation of pain. The studies presented for post-lumbar surgical patients successfully utilized exercise and cognitive interventions. Here are some of the things that we know about exercise. Numerous animal studies have demonstrated that exercise reverses many of the injury-induced changes in the sensory ganglia, spinal cord, and brain. Exercise improves all behavioral markers of pain in injured animals. Studies have shown that exercise may improve symptoms in patients with chronic low back pain with or without surgery. We all know that exercise has positive effects on human structures. Our muscles, joints, bones, and discs require some degree of loading to maintain metabolism and to repair from microtrauma and disuse. Exercise also provides numerous other general benefits, including long-term health. When we physicians treat chronic benign lumbar pain or post-lumbar surgery pain in the setting of no gross instability, infection, fracture, or hardware malfunction over and over from an extensive menu of medications, injections, ablation, devices, and passive treatments, and we continually search for a specific pain generator, we reinforce the presence of a serious problem, we medicalize the symptoms, and we deliver a message of illness. If there is no dangerous pathology, there is no reason not to advise and encourage graded physical therapy and exercise in this population. In conclusion, there is a paucity of literature looking at rehabilitation following unsuccessful lumbar spine surgery. There is some evidence to suggest that active exercise and cognitive intervention is effective. The population is physically deconditioned and psychologically distressed. Chronic pain in this population and in general is complex, and exercise is a promising treatment for chronic pain of any sort. Thank you.
Thank you, Dr. Hartigan. Next, we have Dr. Schneider talking about the injections and the medial branch blocks. And ablation, of course.
Mostly ablation. All right. Hello, everybody. So those are my disclosures. There's nothing relevant to this. So I'm going to cover what I did yesterday in about 30 seconds or a minute, and then we'll move on. So just to be clear, treatment doesn't work unless you're treating the proper diagnosis, right? So we could do